Welcome everyone, good evening. British Interpreter Care Society would like to welcome you to our second series of Ockenden webinars. Tonight we've got great speakers that are lined up, and we'll be focusing on partnership with families, with birthing people, as well as with women. Just few rules for the house. The webinar is in 2 sessions. We'll have a series of questions at the end of the talks, but please post any questions that you may have in the chat box, and we'll pick up your questions as we go along. If you have any other issues or anything else that you'd like to communicate to the panelists, please put it in the chat box as well. So when people think about the Ockenden report and the lessons that have come from Ockenden report, it's not just about Shrewsbury Hospital. It's about all of us. It's about all of us learning and sharing lessons to see how best we can improve the care that we can give to our women and their families. So without wasting much of your time, I would like to introduce 2 of my colleagues that will be chairing the sessions as we're coming up. I'm going to introduce to you Andrew Weeks, Professor Andrew Weeks, who will look about informed choices for birthing families, for women, and also their partners. Over to you, Andrew.
Thank you very much, Chim. I think we're going to start with the maternity, with the families first of all, and I think Vicky Cochrane is going to start that bit off. So maybe Vicky, I'll hand over straight over to you. I'll bounce straight onto you for you to take up, and then we'll come in with our consent section in about 45 minutes. Is that okay?
That is absolutely fine. Okay. So hi everyone, and welcome. As my colleagues have said, I am going to focus on the section around involving women birthing people and their families. So if you just give me a second, and I am going to get my presentation up for you all. And of course, I love a bit of IT. There we go. Fantastic. Okay, so we know that involving women birthing people and families in maternity care should be at the heart of everything that we should do. And reflecting on the interim report from Donna Ockenden, one of the focal points of this in immediate and essential action 2 is that maternity services must ensure that women and their families are listened to, and key to this is that their voices are heard. And I first of all want to echo what Chim has said. In this report, Donna Ockenden is talking to us all. She is not just talking to the team at Shrewsbury and Telford. If we all take a second to think humbly within our services, there are times where we can reflect within our complaints, within our DATEX, within our SI reports, where we haven't got it completely right. And we're here tonight because actually we are all striving to make the changes and move forward together. So the voices of women and their families are key to this. And I just want us to take a moment to read these 3 vignettes from Ockenden. These are incredibly powerful words. And we must make no mistake that actually we must hear these words, and hear these words that we see within our own organisations, and start to make these steps forward. So I just want to remind you, what is immediate and essential action 2? You know, what is it when we say we are talking about maternity services, ensuring that women and families' voices are heard. You know, what are we being asked within our services to have in place to make sure their voices are heard? Well, we need to make sure that we have an independent senior advocate role that both reports within the trust and also within our LMNS boards. And this advocate, and this role is still to be fully decided and understood, must be available to families, attending follow-up meetings with clinicians and leads of services where there are concerns, and in particular, where there has been an adverse outcome. And within each of our trusts, we have to have an ED. So that an ED is a non-exec director who will have specific oversight for maternity services, and will ensure that the voices of women and families are heard and represented at a board level. And they need to work collaboratively with our maternity safety champions. So they need to be doing walk rounds of our maternity services. They need to be attending our meetings. They need to understand the temperature on the floor. And with our CQC inspections, which we all have, and we know they are happening much more frequently just now, they must include an assessment of whether the woman's voice is truly heard throughout the service, and that there is meaningful involvement with the Maternity Voices Partnership. So many people on this call will in some way, shape or form be working incredibly hard just now to pull together the evidence that we all have to submit on the 30th of June to demonstrate where our current compliance is with all of the immediate and essential actions. But the ones that we're looking at under this session are about demonstrating that we have a mechanism for gathering service user feedback, and that we work with service users through our Maternity Voices Partnership, and more extensively, I would say, with community groups and others who have the voice of our service users that may not access our Maternity Voices Partnership, and that we work together to co-produce and co-design our services. This also sits within Maternity Safety Action 7 from the NHSR 10-point plan. And question 15 again wants us to have a robust mechanism for gathering feedback from our service users, and that we work with our service users again to co-produce. So that's all I really have to say. And I think what's most important is those that have come to share with us the work that they are doing. So I am absolutely delighted to welcome some of the team from Shrewsbury and Telford Hospital to come and share the work they're doing. We have Macy, who is a consultant obstetrician and is also the clinical director for obstetrics. And we have Christina Nill and we have Tom Baker, who are project managers within the service. So thank you for joining us, and I'd like to hand over to you.
Thanks, Vicky. I'll just wait for the slides to come up. Lovely, thanks, Tom. So good evening, everyone, and thank you so much for the opportunity to share tonight some of the work we're doing at SAF to involve women, birthing people and their families. As Vicky said, I'm Macy and I'm an obstetrician, and I've got Chris with me, who's our assistant project manager, and Tom, who is the senior project manager for our maternity transformation project. So I think it's important that we address the elephant in the room. And thank you, Vicky and Chim, for those introductions, acknowledging that actually this is about all of us. But I think it's really important that we state that as the Index Trust of the Independent Maternity Review, we absolutely accept the findings and recommendations and are committed to delivering them. But, you know, whilst acknowledging that there is a huge amount of work to be done. And as such, it was December 2019 that a year before the report was published, that the consultant body proposed a programme of work that became the Maternity Transformation Programme last summer. Obviously, during COVID, it was a challenging year to kick it all off. We've set ourselves a really ambitious programme of work, and again, I think it's really important to acknowledge that that has required some significant investment, both in terms of finances, time and personnel. And I know that I am really privileged to have Chris and Tom, who are both full-time experienced project managers. Without them, life would be really, really hard. One of their many roles is to manage a large action plan hosted within project management software, keeping it updated, embedded with evidence, and this forms the basis of our monthly progress meetings that are live streamed to the public. We have that joy tomorrow morning if anybody wanted to watch, that involves all the stakeholders. So our maternity transformation programme consists of 5 work streams, all of which have a project lead, project management support and a wider team. And my work stream is communications and engagements. And we're also really fortunate to have a dedicated maternity comms officer within that work stream. And of course, our Maternity Voices Partnership, who I'd like to publicly thank tonight for all of their hard work, because they are pretty amazing. So within the comms and engagement workstream, we've got 3 main objectives, and the first 2 fall into the comms bit, that being an internal and an external communication programme, but the engagement bit's the bit that really fits into what we're talking about tonight. And this is about being able to implement a user experience system based on themes from the Ockenden report that will enable us to listen to our service users and their families and to understand the change that they want and need, and to be able to meaningfully deliver those changes. So you'll all be familiar, and Vicky showed them earlier, with the immediate and essential actions, and specifically the ones around listening to women and their families and informed consent. And I think the bit that's highlighted here in the box was summed up really nicely by NHS E&I when they stated that what we need to do is produce a clear co-produced plan with the MVPs that demonstrate co-production and co-design of the service improvements, changes and developments. And it's left up to the individual units to decide what that plan looks like. And what we wanted was not just a plan, what we wanted was a system, because this isn't just for 2021. It needs to be something that's embedded into the daily business as usual, and it can evolve with the service over time. And this is where the user experience system really comes into its own. So in a moment, Chris is going to explain the user experience system in detail, but in essence, it takes the approach of addressing a theme at a time over a 2-month cycle. And we've agreed these themes with our MVP, and you can see the ones listed here as a starting point. But inevitably there will be tweaks and new themes added over time, and the order, I'm sure, will change. We've started with partner support, as this past year this has been a really important subject. And even though things are almost back to normal within the hospital at least, we are still aware of areas that can be improved on. And I think the other point that's worth pointing out is that this is about involving staff as well, their experience of this service. So I'm going to let Chris explain the really interesting bit to you.
So next slide, please, Tom. Thank you, Macy. Next slide. Next slide, Tom.
I think it's already moved on, actually, Chris, the card one. Maybe it didn't for you.
I can't see it.
Okay, the user experience card is up on the screen at the moment.
Okay, so to improve our engagement with the MVP and service users, we have developed and co-produced with the MVP something we've called the user experience system, and we're referring to it as the UX for short. So the UX system is a mechanism based on user stories from a project management methodology known as Agile, which is mostly used in software development, but we have adapted it to use it in maternity. So our user experience system involves the MVP gathering user experience cards. Now, a user experience card, we have an example here below, which follows a really simple format. So if it were based on partner support, for example, which is the first theme we're going to address in this first cycle, it would go something along the lines of, as a mother, I want my support partner to be able to attend all of my scans so that I'm fully supported throughout my pregnancy and so that they can be involved too. I know this will have happened when my support partner is welcomed to all of my scans. So the MVP has been really busy, and they've been gathering all of these user experience cards through their social media. They've been using Facebook, Instagram, and Twitter, and they've been using Microsoft Forms to gather the UX card. So once the MVP have gathered these UX cards, they send them to the maternity transformation team, and then our mission is to deliver these improvements. So next slide, please, Tom. So we launched the system last week, and here are a couple of snapshots of some of the posts that the MVP posted on their social media. And 48 hours after launch, we obtained 23 UX cards. 2 were from partners, 1 was from a midwife, 1 was from a doula, and the rest were from women and birthing people. And since then, we've just been receiving more and more UX cards. So it's been a good start. Next slide, please, Tom. So now I'm going to take you through the UX card journey. So first, the UX cards are completed and compiled by our MVP through the social media. Then the UX cards are explained at a special UX workshop with service users and staff. Then the UX cards are prioritized using special agile techniques such as Moscow, which is a must-have, should have, could have, or won't have if it's a task that might be unrealistic or out of scope. And then they are categorized based on effort. So if it's a quick and easy task, then we might give it a small, but then if it's a task that requires more time and effort, then we would give it an extra large, and we would put this into our project plan. Then in a separate meeting with the MVP, we would produce actions from each UX card in that priority order, and then we would deliver those actions. And then meaningful change would be achieved as expressed on the UX card, and it would be fed back to the service users and staff. And then the next cycle would start again based on a separate theme. It's important to say that whilst we're delivering the actions, the MVP will be busy on social media advertising the next theme that's approaching. And with this is the end of the UX card journey, and back over to Macy for the conclusions.
Thanks, Chris. And it's really hard to present something when you can't see the slides, so thank you. So the user experience system has been designed, as Chris said, and adapted from recognised techniques within other industries. And it's really enhancing engagement with our MVP and with the aim of delivering service improvements in a real structured manner. And as Chris said, you may have seen it on the slide there, that it launched on the 13th of June. Within a couple of days, we already had 25 cards, which was quite impressive, really, when you think of how hard it is sometimes to get friends and family feedback in other maternity surveys. We do feel already that the system has strengthened our relationships and is also helping with team building. I think something that we hadn't already talked about was that in order to be really totally transparent, the project management team have actually enabled access for our MVP to the project management software that we just talked about. And this means that they're able to see the action plans, the progress, the evidence that's been embedded. And that's really important, to be really transparent. And we want every part of this work to be co-owned and designed. And even though we're only in the first cycle, we can already see the benefits, and we're really excited about where this can take us. We're confident that this will fulfil the objective to have a clear co-produced plan, but more importantly, the assurance that we are truly listening to women, service users and their families. So I'd like to give some thanks and acknowledgement to the work that Chris and Tom are doing. And I recognise that most units won't have such a valuable dedicated resource that I'm lucky enough to have. But if you are interested in hearing about the work and the different tools being employed that us in the NHS aren't necessarily used to, but have been proven so valuable, then please don't hesitate to get in touch. I think Tom has been busy showing the slides and hopefully being able to keep an eye on the chat as well. So I'd like to just ask him if there was anything that he wants us to address.
Yeah, so while I was showing slides, I couldn't actually see the chat, but one question that's a very good question is, thank you for showing the UX card cycle. Who determines what is out of scope or unachievable, and is this fed back to users? So I can answer that, Macy, but maybe if you'd like to go first.
No, it's a really good question. So on the first meeting that Chris was talking about with the workshop with the MVP, so we've got people are invited to attend it if they, people who submitted the cards, other members of MVP, staff. It's quite a wide audience who are invited to be there, and then that's the forum in which we discuss the request or the concern that's been raised and work out what an action would be. And when we're talking about things that are out of scope, we're talking about, I'd really like to have Costa coffee every day delivered to my bedside, that type of thing, which, you know, I think we'd all agree probably isn't really achievable. But what we're not talking about is the bread and butter of engagement.
Yeah, and if I could just add to that, the going back to the Moscow prioritisation, so the W is for won't have, and so we are very explicit about won't have. So rather than just ignoring it, we would feed back to the person that's raised it with a good reason why we can't deliver it. Another reason for won't have might be something that's against, you know, that might be illegal or against medical norms, that kind of thing. But it's made very explicit so that we close that feedback loop. Another few questions. So a question about how the MVP is funded. Again, I could take the question, Macy, or if you'd like to.
No, you carry on, Tom. Thanks.
Okay, so the MVP chair is remunerated via the LMNS, and we also have a development coordinator who is also remunerated. It's worth mentioning that they are going above and beyond, I think, normal expectations in terms of hours put to this. So we are exploring whether we could increase that remuneration, but we have to go through certain protocols with HR, whether that would change the independent nature of the MVP and things like that. So our MVP development coordinator is benchmarking against other trusts' MVPs to see how our remuneration compares with those, and if there is scope to increase the amount we'd like to. But they are extraordinarily dedicated, as I'm sure all MVPs are. Another question is, Macy, how old can the feedback be? Does the baby have to be a certain age? So I interpret that question, if the birthing person used the service a few years ago, can they still give feedback?
So short answer is yes, absolutely. So it's gone out on social media and people aren't being vetted as such. So absolutely want to hear from everyone.
Another question is, how does the UX method handle other themes that the MVP are hearing that's not the current theme? So Chris, maybe you could take this one, because I know we started off with the partner support theme, but we did have some user experiences that may be related to others. Can you take that one, Chris?
Sure. So we thought with the MVP, we set a list of themes. And the first one is partner support to be addressed in the first cycle. But then the next cycle is going to focus on language and communication. The third cycle is going to focus on supported decision making and so on. And this list is completely flexible. We can add to it. We can change the order. And it's, the MVP will just add more to it as time goes.
Yeah, so if we get a load of user experiences back that seem to be pointing to a theme that we haven't yet captured, we'll add that to the list. So one of the principles of Agile is you change and adapt to changing circumstances, and if it means de-scoping some of the 8 themes we'd initially identified or postponing them and focusing on something which appears more urgent, we can. So that's one of the ways that we'll truly listen to the service users. So we've had another question. Is it possible for all trusts to engage their MVPs to do this? What about trusts that don't have an active MVP? I don't know. Do you have an answer for that, Macy?
Not a good answer, but maybe the question answer at the very end. I know we've got some MVP representatives on the panel tonight. Maybe they could help give us some hints with that as well. How are we doing on time, Vicky?
Yeah, fantastic. Gosh, you've made my job much easier for me tonight, Tom. Next time I think you can come and sit beside me.
I wasn't batting in.
Big thank you. I think this really demonstrates how you can hear from women and birthing people and their experiences very quickly and continue to change and evolve based on what's coming through, and also reprioritize on the basis of what you're hearing. So, there are another couple of questions, and I'm hoping that we've got some time that we can speak to those at the end of it. But if it's okay with you guys and everyone listening, I would like to move on to our second speaker of the evening. And I am delighted to welcome Amy Dignam, who is here to represent the MVP from Chelsea and Westminster Hospital. She is one of the co-chairs in the trust, and she is going to share with you the work that has been undertaken in the trust through the MVP and the team.
Okay, sorry, I couldn't start my video. Okay, so hello everyone. My name is Amy Dignam, and I am one of the MVP co-chairs at Chelsea and Westminster and West Middlesex Hospital. And thank you very much for having me tonight. I'm going to briefly introduce you to how the MVP and the Trust have been working together in partnership to improve maternity services. As you all already know, Maternity Voices Partnership usually is chaired by a lay person. In our case, it's 3 people. And in this group, service users, providers, and others come together to collect feedback and co-produce services and ensure that all women and birthing people and families are at the center of all the work that it's done. And as I just mentioned, our MVP is formed of, it's co-chaired by 3 people, myself, Sarah Espanan, and Zainab Barry. And we are all from different backgrounds and cultures, and this provides a means of drawing on a full range of different skills, abilities, educations, and experiences. We have built a very strong relationship with the staff at Chelsea and Westminster, both at a senior and all levels. And through the years, we developed mutual respect and trust that is enabling us to work in partnership to co-produce information and services. And also it became a support system that truly reflects the needs of pregnant women and birthing people. We work as equal partners, and we come together to structure a process of change that eventually is leading us to a safer, more effective, and reliable type of care that is service user centered. So we do this in various ways. Next slide, please, Vicky. I can't see. I hope that the next slide, you can see next slide. I'm not seeing it. Oh, there you go. So communication is at the base of everything that we do. Sorry, the communication is going too far. Just slides 2 if you can. And then I start again.
Sorry, give me 1 second. Sorry, I don't know quite what my computer's doing here.
Thank you, Vicky, thank you. So, as I was saying, communication is at the base of everything that we do. We communicate regularly with people from the Trust, particularly the consultant midwives and the director of midwifery. They keep us up to date with any changes, and this regular communication system also makes it easy for us to pass on any feedback we might have, or address any concerns, or express new ideas. We know that every time we make contact, we are listened to, and our voices are always taken into consideration. Also, communication is with the outside world, and we have been running 4 social media channels, 2 on Facebook, which focus on our 2 sites, Chelsea West and West Mid. Plus we have an Instagram and a Twitter account for both sites together. In these spaces, we actively work with the Trust on producing helpful information to keep our service users up to date with all that is happening, but also we connect them to other local services. And you can see, if you can go on the next slide, please, Vicky. Thank you. You can see in here some example of our work. These are posts about infant feeding, for example. We liaise with the infant feeding team all the time. The Beyond Birth Living Library, which provides postnatal peer support, particularly for parents who don't qualify for other support, and then also other general information about maternal mental health, physiology of birth, and much, much more. And these social media channels have been particularly important in recent times, as the pandemic has seen unprecedented restriction on face-to-face healthcare encounters. Pregnant women and pregnant people have always been particularly motivated to seek out information online, and the popularity of social media sources of information and support has been growing consistently. Therefore, this form of communication rapidly become a crucial tool for COVID-specific information generation and dissemination. So as you can see, the top middle post was during the first wave of COVID-19, where we introduced staff wearing the mask to help service user get used to this kind of new normal and be prepared to what they would see when they came into the units. And if you can go to the next slide, please, Vicky. So during the pandemic, we worked with our consultant midwife, Natalie Carter, and we introduced a live Ask the Midwife service. And then we branched that out to include others, some with a focus on mental health or infant feeding. And this work has evolved into a regular fortnightly service update with one of our consultant midwives doing the lives, usually Natalie Carter or Louise Nunn. And during these live events, we help by collecting service users' questions prior to the session, and by attending the live session too, assisting via the chat box, by adding all the relevant links that get mentioned during the talk. And we had, and we are still having great feedback on this, and women and birthing people really appreciate this, this session. Next slide, please. So moving on, we have co-produced and hosted several surveys for the service in relation to getting feedback from women and birthing people. In here, you can see a couple of examples. We co-produced a survey with Health Watch Richmond and the Trust, asking for service user experience during the first wave of COVID-19. At the same time, we were involved in the co-production of the London-wide Women's Experience Survey. And both of these really highlighted many of the challenges that pregnant and birthing people and their supporters faced during the first wave. And this led to a workshop for service users and staff on improving the experience in postnatal ward. And then a little later, we launched our surveys focused on Black and Brown people and how they experience their care in maternity from a cultural safety perspective. The survey aimed to identify specific areas where changes in the maternity service at Child West and West Mid are needed to reduce unequal care and improve outcomes, and all in all, just to better the experience that pregnant women and birthing people with diverse backgrounds have within our trust. So this work as well was done by us chairs, and again working closely with the consultant midwives, the director of midwifery, and all the key staff, and with the constant input of many members of the MVP. And alongside the survey, we have organized, and we are organizing a series of online listening events, which aim to provide a safe space for service users to come and talk to us about their maternity experience, whilst it's a chance for us to really be listening and understand what part of our service works and what instead needs a little bit of improving. So the first listening event was co-produced with Natalie Carter, and the cultural safety champions joined us for this too, which hugely enhanced the value of the event itself and future work. We are organizing another one at the moment, which will be focusing on LGBTQ plus families. Next slide, please, Vicky. So as chairs of the MVP, we attend, excuse me, a number of forums and groups to ensure strong focus on the service user voice, including improvement of the induction of labour procedure and the maternity transformation project in Northwest London. The challenge is always to prioritise what is possible within the limited resources that we have available. Early on in the first wave of COVID-19, after a discussion about the guidance that the MVP chair should be involved in any discussion about closing part of the service, we were invited to join the COVID-19 senior management call every week, where all decisions have been taken about service changes. And our views and our feedback was and is always warmly welcomed. And also, again, all changes in here are being co-produced wherever possible. These calls continue with the three of us, the three chair, rotating attendance. And we can say we are very proud that we've been able to lead the way and establish this inclusion as business as usual. We also regularly participate in interviews for senior staff, having a voice on the employment of senior position in the service. Next, actually, no, sorry, Vicky, that's okay, just stay there. And we also have quarterly meetings for all involved, which we are now experimenting with that and trying a new format, setting this up to be bi-monthly instead. And this new framework wants to offer a specific space for service users to come together before the main meeting takes place. And so we can really listen and reflect on any feedback given, whilst also create a sense of community based on support and trust amongst all lay members. This discussion will then be summarized in the main meeting, and of course lay members are welcome to stay on and engage with all the project work and discussion on an equal basis. And finally, all of this work that I've just illustrated here today is only possible due to the warm and respectful relationship between staff and service users across both sides and at all levels. I can say that we are really proud to be part of the team working to continually support and improve the services for women, birthing people and families. So just to very quickly finish, I just wanted to, on behalf of my other two co-chairs as well, wanted to say a very public and heartfelt thank you to Vicky, Natalie, and all the wonderful staff at Child West and Westmead. Thank you so much.
Thank you, Amy, for your fantastic presentation. I think it does highlight lots of different ways in which we can work with women, birthing people and their families. And that for me is what both of the presentations has given us. It's given us different points of food for thought in how different services could work towards doing this, you know, built up over time. We've got about 5 minutes left for questions. And I've got a couple of questions that were put into the chat box during your presentation, Amy. And then I think there's probably one question that applies to both of the presentations. So the first question that's there is the same as actually was asked of the previous speakers, and that's around funding. Are the MVP chairs remunerated for their work, and how much funding is received to do all of the work that you're currently doing?
Am I allowed to talk about figures? We are receiving, obviously, we are remunerated monthly. It's 3 of us, so we work in theory 2 days per month each, so 6 days a month. Although we do sometimes extend our work you know, we work more than 2 days a month each, that's for sure. But yes, we are trying different ways to make sure that the work that we do is remunerated. Like, for example, recently with the listening event, we applied for fundings from CW+, and we worked on this as an external kind of project alongside with all the work that we do. So we're trying to explore different ways to be able to put in more hours and do more work.
Fantastic, thank you for that answer. And then so one of the comments in the box is a great example of collaborative working, so I wanted to make sure we shared that with you. But a question that has come up for both of the examples is around the hard to reach voices. So, you know, for service users who don't use social media, who can't attend meetings or send emails, we know that those are often the most vulnerable and those where the biggest inequality sits. So I don't know if Amy, you and Macy want to comment on, you know, what you're currently doing and what you plan to do to try and make sure that those voices are heard within the work that you're doing.
Macy, would you like to go first?
Can do. To be completely honest, it's really, really hard. And I'd be really grateful for ideas from everybody on this webinar as well, if they've got really reliable ways of doing it. We've had this conversation with our MVP quite a lot because they're constantly going out into different groups and trying to access. Demographically in our area, it's not very diverse. So whether that makes it easier, whether that actually makes it more difficult because there aren't groups that you can go and interact with, I'm not sure. So I don't have a good answer for you, if I'm being completely honest, but I'd be really grateful to hear ideas.
Yes, I think that you're right, Vicky. It's very difficult to reach out to specific communities. And we have learned many times before that social media is just not good enough. And also because of all the restriction that we have been facing the past 18 months, we are not able to physically go out in the community and reach out all the places where they would be socially engaging. But for our recent survey for Black and Brown women, what I can say that has really helped us was Natalie sending a text to all. And the numbers have changed overnight. So Natalie, if you want to add anything.
Yeah, I'm happy to speak to that a bit. Hi everybody, I'm Natalie, I'm one of the consultant midwives working with our MVP. It absolutely is really challenging, and we've used several different ways to try to engage all people who use our service. We've used our notes, so for those who don't necessarily have access to phones, we've put links to how they can complete surveys either online or on paper on our notes, particularly our postnatal notes, and we've encouraged all of our community midwives to help women complete and do that within their own homes when they're visiting, to support some of that, or at least signposting to it. We've sent text messages. Predominantly women do have a mobile phone that they are accessing, so we have tried text messages, which has shown to be one of our greatest ways of increasing those accessing the survey online, by texting them the link. We've also been very grateful for volunteers in our trust. There's a central service of volunteers, and we've often been able to ask for support for volunteers to come. And from our comms department, we've gotten tablets, and we've put the surveys that we've done up onto the tablets. And then our volunteers, particularly where our users from the MVP are not able to come in and walk the patch at the moment like they used to because of COVID, our volunteers have been able to actually, sorry, my battery, our volunteers can access women in the inpatient areas who are, you know, using the service at the moment and giving them the tablets to fill in. And then we always offer an opportunity for women to then leave their contact details or engage with our MVP, whether they want to do that verbally or by phone, email, contact, where they want to help in the future or receive information about how they can get involved in the future. And slowly but surely, what we hope is that we engage those different groups of people, and that is going to build, and there's a trust that develops in why we're accessing those communities and what we want to hear. And then, a bit like with our recent survey for Black and brown women, some of our midwives were able to highlight women from certain areas as well that they felt wanted to give feedback and alert them to the listening event that we held. And then they've been able to access that, and now they are branching out into their communities and saying, actually, this that I just went to was a really positive experience, and I felt really heard, and it was a safe space. And we, as we plan more listening events, we hope that those communities will grow from that trust that will develop.
Thanks, Natalie. There's some really, really good ideas there. And actually, one of the things you mentioned was, we're changing our electronic notes in the autumn, and it's going to have a function that can push out things like information, links to videos, and links to things like this. So definitely take on board your ideas. Thank you.
Thank you. Thank you for your responses to the questions, and thank you to those that are on the webinar tonight for asking these questions. It's so important, because be sure for the one person that asked the question, somebody else really wants to ask it but hasn't. So I just want to finish off this part of our session with a big thank you to Macy, Christina, Tom, Amy and Natalie for your contribution. And now I'm going to hand over to Andrew to follow on with the second part of tonight's webinar.
Thanks very much, Vicky. Fascinating stuff. Somebody once said to me that you need to hold meetings out in the community, and the more uncomfortable the place is that you're holding the meeting, and the more difficult it is to either get there, or that you feel I'm going to put my foot into it because this is culturally different to what I'm used to, then you're in the right place, because they'll feel exactly the same entering the services where we're comfortable. Okay, so let's move on to the thorny issue of consent. As you know, over these sessions, we're going through the different immediate and essential actions from the draft Ockenden report. And you'll know that number 7 of those is all about consent. And I just want to talk a little bit about the background to it and introduce it, and then we'll go into getting some examples and having some speakers on some specific issues about it. So let me see if I can share my screen. Is this right? So I'm Andrew Weeks. I'm a clinical academic in Liverpool. And in the same way that Vicky did earlier, I'm hoping to no, and it's not going to happen. Hang on, I'm going to have to restart that. Apologies. Let me see if I can go into that and start. Oh, that's very interesting. And you're still seeing that first screen, aren't you? Eek. Oh dear. Okay, let me try again. Don't you love IT, eh? Okay, that. Yes, that is completely failing me, I'm afraid. Let's have a look and see if we can. How's that? Is that any better? How's that? Can you see your main screen there?
Andrew, we can see the main screen there. We just needed
Perfect.
to go on to start the slideshow.
How's that?
It's on the second slide now.
Perfect. Okay, at last. Good. No matter how often you try these things beforehand, you can be sure that they're going to go wrong just on the time when you try them. Okay, so in the same way that Vicky did earlier, let's just have a look at a couple of vignettes from the report. Here's one about a woman who was known to have a big baby, and she was refused her request for a cesarean section and encouraged to labour. And you can see that it wasn't a good outcome. And the key issue here was that she was refused her request for a cesarean section. Another one, a woman had a failed von Teuse, an emergency section in a previous pregnancy, and in the next pregnancy, the baby was found to be macrosomic or large on scan at 36 weeks. The woman was admitted in labour, and despite requests for a cesarean section, she was persuaded to attempt a vaginal birth. And you could see how things do not turn out well. Now, the interesting thing about that is that when you go to the immediate and essential action number 7, it's called informed consent, and yet looking at the essential actions, it's a slightly different version of consent to that which we normally talk about. So all trusts must ensure women have ready access to accurate information to ensure their informed choice of intended place of birth and mode of birth, including maternal choice for caesarean delivery. Now, that's not traditionally what we'd talk about in consent. And if you look, here we go further on to the right, where it says all maternity services must ensure the provision of accurate, contemporaneous, evidence-based information, and this must include all aspects of maternity care. The second section, women must be enabled to participate equally in all decision-making processes and to make informed choices. And then once they've made those choices must be respected. Now, when I think of normally about informed consent, actually I think about the system, whether I'm a consultant as part of that system or a midwife. We're planning an intervention on somebody and you're seeking an informed agreement. And of course, there's the consent forms, which are, I guess they're a prompt, they're a way of recording our information and having a record for us both of what has been discussed. But this, of course, extends that concept really quite considerably beyond that. It's not just about an institution seeking to get consent to intervene, but it's about sometimes here wanting a caesarean section and not being respected. So it's a service user wanting an intervention which isn't immediately on offer or is being refused, or in fact not wanting the default which is being offered. And this really isn't quite about informed consent. It's a much bigger concept than that. Is it about actually consent in reverse? It's almost about consent of the doctor or the system to what is being requested. Or you could take it further to say that this is about having consent for normal birth. Now, both of those things are very problematic. And in fact, when we talk about, in this situation, informed consent, I think we're probably much easier talking about informed choice. And I think that covers the concept far better. And what does informed choice involve? Well, clearly it's about trying as much as possible to give good information. I despair sometimes about the consent forms that we use, and we can come back to that in the discussion afterwards. But what you're really wanting is good, accurate information. What you're not wanting is, you know how when you get a new credit card and there's pages of small print and you know you've got a sign at the bottom, so you just go ahead with it. Or when you're updating your Apple iPad and you scroll down and you just scroll, and it says, I agree. And of course, nobody reads that. So that's not really good information. What we're wanting is good, accurate, contemporaneous information. But it's more than that. It's also about shared decision-making and respecting women's choices. And these are two sort of quite different but complementary. And actually, the informed consent is really just the end point at the end of these discussions. So we got two fantastic speakers who I'm delighted, well, three fantastic speakers who I'm delighted who are with us. So you'll know that we put out abstracts, and the team from Maidstone and Tunbridge Wells and Sarah Grayson and Shazia Nazir are here to talk on their behalf, and they're going to talk about the good communication and accurate information. And then Maria Booker from Birthrights is going to take us through some of the shared decision-making and consent issues. So I'll turn first of all to Sarah and Shazia. Thank you. And I'll see if I can share screens here, because I think my, here we go, let's see if this works.
Fantastic, Andrew. I hope everyone can hear me, and thank you for listening to our presentation. So my name is Sarah Gregson. I'm a midwife at Maidstone and Tunbridge Wells. which is down in Kent, of course. And I'm going to be presenting this with my colleague Shazia Nazir, who's going to jump in sort of halfway through. So I'm going to be covering what we've done and why we've done it. And then Shazia is going to be talking about how we've used this tool that we've developed in clinical practice, and particularly how we've embedded it into clinical practice. So could I have the next slide, please, Andrew? And in actual fact, I'm going to skip on this slide because Andrew's already very well discussed this whole issue of informed consent. So could we perhaps just go to the next one, as we're short of time. Now, I'm going to be a little bit controversial here because informed choice, this is a really buzz thing at the moment, isn't it? It was in the maternity review, it's been very much in Ockenden. And I'm actually going to say, is this rhetoric or reality? You know, when women ask the questions that I put down here, what do we tell them? Do we give them this information? You know, shouldn't they be entitled to have this information? So, for example, let me pick up on the second one. So if I have an induction of labour, how likely am I to have a normal birth if it's my first baby? And how much does this change if I've already had a baby? You know, questions like that, can staff answer those questions? Should they be able to answer those questions? Should women have that information? Well, just skip down to the bottom comment that we had from friends and family, which I think really just sums this up for us. And this comment, I think, is very pertinent. You midwives and doctors must have the data, you just don't share it. And I think if we're all really honest, we know that our lives, our working lives, we spend a huge amount of time putting all this data on the maternity system, and that's the end of it. We don't see it. Or perhaps only senior people see it, but the frontline staff don't see it. Now, Shazia and I were discussing this, and we, you know, when we kind of thought about this, we thought, well, let's test this out. So we actually did a survey. I think we had about 60 people altogether, midwives, doctors, obstetricians, all grades, so some juniors, some middle grades, some very senior doctors. But what we actually found was that across the region, the majority were unable to answer simple questions like the ones that I've got on this slide about the local birth outcome data. And I have to say, it's not their fault. It's not our staff's fault that they can't answer those questions with the data and the numbers, because we, and I'm talking about we as senior people, have not given it to staff in an accessible way. Could I have the next slide, please, Andrew? So thinking about how can we make the data accessible to women, because we want to do that, but you know, we can't just throw the data at women and expect them to be able to interpret it and work it all out. So we really need to think about how we can make it accessible to them, and actually perhaps to take a step back and actually realise that first of all, we need to make the data accessible to our frontline staff so they can actually discuss it and explain it to women. So at Maitland and Tunbridge Wells, we developed more than 20 years ago, well before my time there, a system to classify all pregnant women into different groups, depending on their parity, how many babies they got on board, whether heads down, whether the labour is spontaneous or induced, or whether they've had a previous cesarean. And I suspect that a lot of you are very familiar with the Robson classification system. You'll know that there's actually 9 groups in total, but the first 5 are, you know, accommodate the vast majority of women. And I think most units now will use this tool or a similar tool to analyse maternity data. So senior staff are used to looking at problems like, you know, have we got a problem with third-degree tears, for example? Now, is it primates or multips or whatever? And we drill down into the data. So what we were saying, what we were thinking was, could we make this data accessible to staff who could then share it with women and birthing people? Could I have the next slide, please? And this is actually what we've done. So we have made a birth planning infographic booklet. Now, what this actually means is that we have a booklet that's in 2 sections. So the first section contains the 5 pages that you can see at the bottom of the screen, which is 1 page for each group. So, for example, from left to right, we've got first-time mums, spontaneous labour, then first-time mums who are induced, then we've got second-time mums, spontaneous labour, second-time mums who are induced, and then women who've had a previous cesarean. And that will cover most women who give birth in our maternity unit. Now, obviously, there is some of this data already available in national data, but remember, it's 2 to 3 years out of date, and it's not stratified and made meaningful in terms of breaking it down for first-time mums and second-time mums and, you know, mums who've had a previous cesarean. So making this infographic means that we don't have to rely on staff recalling the data, because actually, if you look at the data, there's a lot of figures to remember. I remember that it changes every year. It will vary. When you look at some of the data there are also some things that have to be explained. For example, all the different outcomes you have depending on birthplace. So there's a bit on the back page that has some information for staff to kind of support what they should be explaining to women and birthing people when they're talking to them about the data. And then the second bit on that front sheet, we'll have a look at in a minute. These are discussion points for improving the birth experience and clinical outcomes. And then section 2 of the booklet is a summary of supporting research for discussion points. So could we just move to the next slide, please? So this is at the bottom of each infographic. And what this is just little icons for all the things that are available for women in the unit to improve clinical outcomes and hopefully to improve their birth experience. And the point is, again, that some women can really miss out on this information. So I'm just going to home in on 2 things. Let's look at minimising perineal trauma. Now, we know that there's evidence around antenatal perineal massage, but, you know, some clinicians fail to tell that to women, perhaps time factors, or perhaps they don't agree with it, or for whatever reason. But really, this information has got to be there for everybody. Another example would be water for labour. So I'm thinking now of perhaps an obstetrician who might not know anything about water for labour, and that's all very much, you know, discuss that with your midwife. But what about a woman who perhaps is seeing an obstetrician for most of her antenatal consultations? So, you know, an obstetrician, we should be helping obstetricians to have that information about water so that they can just give a summary to women, whether it's good or bad, and also whether it is possible, you know, perhaps for a higher risk woman to be able to use water for labour, and if so, how they can do that. So could we just go to the next slide, please? And this is where section 2 comes in. It's very small here, and I'm not sure if you can see it on your screen, but each of those different therapies and practical practices has just got a summary of the Cochrane research around it. So, for example, if we think about our obstetrician that may not know anything about water, they can just turn to the bit at the back and actually see that Cochrane supports its use for, you know, for example, for the first stage of labour and what it says. And it's got that for all of these different therapies or clinical practices. So I'm just going to hand over to Shazia now to talk to you about an example of how we can use these infographics in clinical practice. Shazia, I'm hoping that you're there.
I am there, Sarah. Can you hear me?
Yes,
okay.
I can
So
hear you.
Thank you, Andrew, for giving us the opportunity to present our work. So I'm Shazia, I'm one of the consultant obstetricians at MTW, and I'm the clinical lead for the Kent and Medway LMNS as well. So I did my antenatal clinic this morning, and I've used MTW infographics for a lady who was requesting induction of labor for pelvic girdle pain. So Andrew, if you move on to the slide. So I said, I would like to share something with you. And I said, so at MTW, we collect this data, which is very recent in the last financial year. And it's women like yourself. So it's not national, it's regional. And as soon as I utter that word, I can see the women sit up and I get the engagement, because it is very personalized and very customized. And you can see the difference. The fact is how the place of birth and the intervention actually impacts on the clinical outcome. So you can see if this woman choose to deliver at Tunbridge Wells, the spontaneous vaginal delivery rate was 61%, but if we induce her, the spontaneous vaginal delivery is 42%. And I always add a caveat, because this is not a randomized control trial where we have taken into account all variables. So I always tell them that it could be the process of induction of labor, or it could be the condition you're being offered induction of labor for. But the intervention does change your clinical outcomes, and so forth and so on. So very powerful. And we worked on this project for the last 3 years and several versions, and we have distilled it to this presentation. It comes in a very beautiful booklet. And there is a QR code on it. And today I used it. The patient was able to scan the QR code on her smart device and had it in front of her and her partner. Next slide, please.
We must keep moving, Shazia, because we're running out of time. This is fascinating, but please let's just...
so I'm going to be really quick. So we had an amazing staff engagement because it made sense and it made a change to their working life. So we used it as a part of Rhetoric training program and email, Facebook, teaching, ward rounds. It's accessible in booklet form in all clinical areas. And we have made supporting videos using local staff to demonstrate how to use this in clinical practice and the QR code. And it's been shared regionally across Kent and Medway LMNS. And at the last 2 slides are just testimonial from patient and staff. So I'll let you read it and then I'll take any questions.
Fantastic.
Next slide, please.
Shazia. Sarah, thank you so much for sharing all that. Brilliant. We often have difficulty knowing exactly how to get the information right. So it's brilliant that you've shown us a way. What I would suggest we do is have joint questions at the end, because I think Maria is waiting to come on, and I know that people will want to leave in about 20 minutes. So what we can maybe do is bring questions together all at the end. Is that okay? I'm seeing questions coming through, so this will be good. But let me pass on to Maria Booker, who people will know. I think you've had a bit of a busy week at Birthrights this week. So thank you for sharing the time to come and talk to us about consent, which I know is very close to your heart.
Thanks very much, Andrew, and thank you very much for inviting me to be part of this evening. So I'm just going to try and work out how to share my screen. Okay, you'll see that. Brilliant. So talking tonight about optimizing consent processes. So I thought we'd just go back to the beginning and understand why we're looking at this issue. So Ockenden aside, I think we know that we still have an issue with consent in maternity care. It's been 6 years now since the Montgomery versus Lanarkshire judgment. And last year, Birthrights did a survey with Mumsnet to try and ascertain how much that judgment had made a difference to clinical practice. And the results weren't very encouraging, I have to say. You'll see, some of those statistics on the slide there. But I think the main one for me is that less than half of the respondents to that survey felt that they were the primary decision maker in their maternity care, even though that is the legal position. So this is something we clearly need to address. And it's been an issue for many years, way beyond Montgomery versus Lanarkshire in terms of the actual judgment, because when Sam Montgomery was born in 1999, all of the best practice guidance from the GMC, from the BMA, from the NHS, all supported the approach of having these in-depth conversations with patients and setting out all the reasonable options and sharing the risks and the evidence base. But you know, we're now 20 years on from that, and we're still having these conversations. So it's clearly something that Donna Ockenden felt needed to be urgently addressed. But I think the reason that we haven't made more progress on it in some ways is because it's quite complicated. And I thought tonight we could just have a whistle-stop tour through the breadth and depth of consent, and hopefully that will provide some inspiration about all the different ways that consent can be improved in maternity services. So if we look at consent in a multi-layered way, we need to start with beliefs and values. And the fundamental starting place is that healthcare professionals need to absolutely believe that it is a woman or a birthing person's right to make these decisions about what happens to them in a maternity care. And you know, there's still quite a lot of ambivalence about that. Even just earlier this week when we had a session with obstetricians, statements like, I support the human rights, but, and the but is always about, but not if somebody's going to make a choice I don't agree with, or something to those, you know, to that extent. And it's something we really need to acknowledge and address, and we need to look at where those views are coming from, what's behind them. Is it a fear? Is it pressures within the system? But I think we need to acknowledge that there is still an issue about how some healthcare professionals feel about women and birthing people being in the driving seat. And I think that's also true for women and birthing people. I think there's still some way to go till we get to a point where women and birthing people also believe that it's their decision and they can, you know, make that for themselves with the guidance of healthcare professionals. We still hear a lot of this, I wasn't allowed, or, you know, that wasn't an option. And we need to raise awareness so that women and birthing people do feel that it's their choice. And the strange thing is that, you know, this is a right that is very strongly upheld in both human rights law and common law in the UK, and yet culture still seems to have quite a long way to catch up. I just included this this quote from somebody who contacted our advice service and featured in one of our videos. We don't often see healthcare professionals express it quite this explicitly, but these are perhaps some of the values and beliefs that some healthcare professionals still have. So it says, I asked her why she had gone ahead with the forceps delivery procedure when I made very clear in my birth plan, both verbally and in my birth plan, that I wasn't happy with that. She almost seemed flabbergasted. She said to me, doctors and patients are not equal. What kind of system would we have if we allowed patients to make decisions about their healthcare? That would be like saying doctors and patients are equal. So still some way to go on fundamental beliefs and values in some cases. And I think there's also some assumptions about consent that we need to make explicit. When we train healthcare professionals, one of the things that we often hear is that, or it feels like, the consent is one moment in time, it's that one decision, and healthcare professionals are concerned about how they get that consent in that moment with all the pressures of time and resources. But actually consent is a journey, and it should start even before maternity care starts. And there might be some landmark points in that journey where we have like in-depth discussions, and you know, those conversations and that evidence is unearthed. But it's still a journey. Women and birthing people can still change their mind. It's fluid. Somebody might decide that they want a home birth at the beginning of their pregnancy, but change their mind by the end, and vice versa. And we need to recognise that consent is a journey and a fluid process, not one moment in time. And another assumption that I think we need to make explicit is exactly what Andrew referred to earlier about whether it's about informed choice or informed consent. I think we focus a lot, rightly, about those kind of difficult decisions about weighing up the risks and benefits of a caesarean versus a vaginal birth, for example. But a lot of the consent issues we see on our advice line are simply about women being touched, sometimes in very intimate places, or having interventions done without their consent. But it might be quite a simple intervention. A vaginal examination, for example, it's not a hard intellectual discussion about whether you want one or not. But while that's very routine for healthcare professionals, it's not routine for women and birthing people. And so we need to make sure that we keep some focus on just that quite simple explanation of consent to, just asking permission to go ahead with an intervention, even if it's quite a simple one. So having looked at beliefs and values and assumptions, those really fundamental things at the bottom, we then get into those conversations, those choice conversations. What's going on within those interactions? Do healthcare professionals have the soft skills and the communication skills to empower women and birthing people to feel like they're an equal in that conversation? Do they have the time? Do they have the resources? Is it accessible for the woman or the birthing person? Do they have the language support that they need? Do they have other support needs met? Do they feel culturally safe? And I'd like to draw your attention to a study that's been done by a team at UCL, led by Jackie Nichols, who's published a couple of papers, which I think really shine a light and show some insights about what's happening in these conversations at the moment. So the first paper that they published in 2019 talks about the fact that there's a culture of expected compliance in maternity care. I think that's a brilliant phrase. I think it sums up very well what lots of women and birthing people feel about going through maternity care. Not that they're told always explicitly that they can't do something, but there's an expectation that they're going to follow recommendations. Their study also found that the relational context of a conversation is really important. So often where the woman or the birthing person trusts the healthcare professional, has a good relationship with them, they might actually want less information. They might go with what they've been told because they inherently trust what that professional is saying to them. And they also found, which really links well to what Sarah and Shazia were talking about, that women want individualised information, but that healthcare professionals actually find it quite hard to give that information. So there's a second paper that's just been published quite recently, that the link that's drawn from the same research study. And this paper talks about the fact that these encounters between healthcare professionals and individuals are framed very clinically. It's about a clinical decision, and clinical risk dominates the narrative. That's how the healthcare professional sets out. That's what the decision's about. And yet there's a parallel narrative going on for the woman or the birthing person, which is on a completely different track. It's talking about, you know, the place of birth and partner influence, and these are the factors that matter and that are really important to that individual. And they're almost completely different to what the healthcare professional is concerned about. And we've seen this a lot during the pandemic. So perhaps people making different decisions about where they might give birth because of whether their partner can be present, because that's the overriding concern to them, rather than where clinically it might be recommended. And the researchers talked about the fact that you can develop a cross-cutting narrative, but it takes trust and empathy and empowering language. And there's a real question here about how we empower healthcare professionals to have those conversations with women and birthing people. So we've looked at the beliefs and the values level, we've looked at the skills and the knowledge and what happens in that encounter about a choice. And then there's a question of what the wider system does with that decision. So some of the things that we hear quite frequently at birth rights are that women and birthing people are let down by the system because they think they've had this conversation, they think they've come to a decision, and yet there isn't that continuity in the system, which means that they're going to get that expectation met. So for example, I remember talking to a woman who had had a really good conversation with a midwife about whether she should have a VBAC or a cesarean, really in-depth conversation, really good quality information. She'd been attracted to sort of having a VBAC mainly because she could still labour in water, and she was told that if she wanted to do that, there'd be the option of monitoring her in water, and that she could still do that, and that was an option. And that was one of the main reasons she went for a VBAC. But when she went into labour, she arrived at the unit, and the telemetry equipment was locked in a cupboard that nobody could access, which meant she couldn't go in the water. And to her, that was a crushing disappointment. And it's just about having those continuity of processes that was so important to that woman. It might have just been an administrative detail to the unit, but it was really important to that woman that she couldn't have her expectation fulfilled. So I think we need to look at communication within the team, how decisions are respected. I think in the best units, and I know we've got some people on the call who've told me about these systems, people have a really good relationship with their colleagues. If they go into a birth options clinic and they agree that a woman should have a cesarean, their colleagues accept that decision. They accept that they know that person will have gone through all the risks and benefits, will have had a really in-depth conversation, and they trust that that's been done well. And that means the woman doesn't have to keep repeating or keep revisiting that decision over and over again. There's also questions about, what's rewarded, what's punished, what's seen as a good thing. Or so, if you have a colleague who is really woman-centered, who really tries to do their best to ensure that an individual's decisions are respected, is that person seen as a hero or a heroine, or are they seen as a bit of a maverick or a soft touch? And it's all these kind of softer cultural influences that affect how consent is handled within a unit. So, a few ideas for optimizing consent. These are just some of the good examples that we've seen. Birth options clinics, giving women and birthing people a really good chance to have those in-depth conversations where you can go through all the evidence. Multidisciplinary clinics where you bring together perhaps obstetricians and psychiatrists for women and birthing people who might have particular mental health needs. Really co-producing guidelines with service users, really addressing both service user concerns and the concerns of healthcare professionals. Personalised care planning, for example, low threshold cesareans, options that women might not have thought about. We've also heard about trusts running antenatal classes in other languages, having specialist posts where they've got particular communities. Binash Neem, who works with us on the racial injustice inquiry, has talked about the clinic she runs in the mosque, which can help people feel more at ease, perhaps more able to ask questions and to really get the information they need. And the localised information we've heard from Maidstone and Tunbridge Wells, I think is absolutely brilliant. But it's important to note that these things are things that are chipping away at the tip of the iceberg above the surface. But we also need to remember to go back to those beliefs and values and assumptions. So if you've got staff who really don't fundamentally believe that women should be making those choices, you can have all those additional posts and clinics and all those additional brilliant resources, but it's probably not going to make a difference overall to the culture without addressing some of those fundamentals. So if anybody's interested in doing birth rights training, please do get in touch. We're really keen to work with trusts on this consent issue. And also the Institute of Personalised Care has just launched an e-learning module. I was one of the authors along with Catherine Gutteridge and Sarah Winfield and Natasha Smith. It's a 30-minute module, doesn't take long to do, and it's free of charge and easy to access. That's a really good starting point for thinking about consent as well. It might also involve looking at the multidisciplinary team, how well does it work together, addressing communication and processes. And these are not easy things to do, and they're perhaps things that are less visible as well, but they're really important if we're really going to make a difference to the culture of consent. So I urge you all to have an honest and root cause look at the barriers to consent, look at it in a broad way, in a deep way, and look at how you can address them. I'm sure the people on this call are not here to tick a box, even though I understand that action has to be taken urgently to address the Ockenden recommendation, but there's so much more at stake than that. We need to involve service users in all of that to really co-produce these solutions and analyse complaints and have regular meetings and really involve service users in the improvement work. And we also need to listen to staff. So I hope that you will think about an improvement plan on consent that will look at addressing issues both above the surface and under the surface. And please do get in touch with us at Birth Rights if we can help. Thank you.
Brilliant. Thank you so much, Maria. Wow, what a sort of authoritative and fascinating presentation. Brilliant. So we were planning to have 15 minutes. Actually, we've all gone a little bit over our time, so we're just got time for a few questions. Sarah and Shazia, a question which has come up in the chat was how frequently do you update these? Because they look like a huge amount of work to do. That's a challenging bit of work. Can you update them frequently?
Yeah, so can I take that question, Sarah?
Yeah,
so we have brilliant digital midwives. There are 3 of them, and they are updated every year, run through a financial year. So the latest booklets contain the data from the 1st of April last year to 31st of March 2021. And the plan is to update them every year because that data has been collected in FDW for 20 years. Anyway.
Okay, brilliant. Thank you. Maria, a question which has come up as we were preparing for this actually was about shared decision making. A lot of people don't like this term shared decision making, and it is sort of directly there in the Ockenden report. And I've actually heard people on both sides. I've heard people say exactly what was in your presentation. Well, not quite exactly what was in your presentation, but I've heard very much those attitudes. And other people saying, shared, why would we share it with the doctors? It's a woman's body. What's all that about? Shared, where do you stand on this shared decision-making question?
We don't like the term. It's the honest answer. I think it's important to recognise that when many people talk about shared decision-making, they do mean they are trying to aim for a Montgomery type process that does empower the individual to make the informed decision that's right for them, and that's what they mean when they use that term. But I think it just muddies the water, and that's the problem with it. It's too easy to think that it's a shared decision, which means that both the healthcare professional and the individual have to agree, and that's just not the legal reality. Women are entitled to make decisions or refuse treatment even if the healthcare professional doesn't agree with them, and I think it's important that we're clear in our language. And so I would support a move away from that term to something like supported decision making or informed decision making.
Informed decision making is a better, or informed choice, I guess. Yeah. Okay. I think, where are we up to with questions? I think we're just about at the end of the questions. I can't see any more coming through, but that's quite convenient because it's just about past. And I was going to hand over to Louise, who is just going to finish off as president of BICS. I hope that this has all been interesting to you, everybody watching. It's certainly been fascinating to me. And I hope that you can see that BICS is trying to be part of this process of the transformation of maternity care, and certainly getting these discussions out there, because actually a lot of people hadn't thought too much about this, I think. And so actually having speakers like yourself and examples of great practice is really important. So I'll hand over to Louise and thank you all, Maria, Sarah, Shazia, for coming along and presenting this evening. Louise.
Thank you. So I'm going to bring us back to how Vicky really kicked off the evening with Essential Action 2 from the Ockenden report. Maternity services must ensure that women, birthing people and their families are listened to with their voices heard. As many of you may know, the unofficial BICS motto is "Be the Change," and it's so encouraging to hear of all of these amazing changes taking place in maternity services in the UK. So my challenge to everyone is please continue to be the change with warmth and respect. I'm very proud of hearing about everything that we've heard of this evening, and proud of the bit that BICS is playing in pushing this on the wider maternity agenda. We hope to see you all next Monday evening for the final of these 3 BICS Ockenden webinars. That one is going to be around MDT working and training. The link for registration is on the BICS website. And then lastly, if you're not a BICS member, I guess we have to say why not? Please do consider joining. Together we are stronger, and you'll find all membership details available on the website. Thank you all so much for coming and for your participation. It's been a great evening, and have a good rest of your evening. Rest well and enjoy your days tomorrow. Good night.